Hello, Cardiology Update, listeners, readers, and viewers. My name is Chadi Alraies from Detroit Medical Center, and today we're coming to you with another episode related to STEMI and cardiogenic shock to patients presenting to non-PCI capable centers. This is a very hot topic and oftentimes studied and also presented and asked on the board exams, but also in clinical practice in rural areas. This is a very important study to highlight some new strategies. In this study, patients who are presented with STEMI and cardiogenic shock looked into based on multiple years back in Canada. In this study, they involved more than 400 patients who presented with ST elevation, myocardial infarction, and cardiogenic shock to non-PCI capable PCI hospital. And in this study, they looked into pharmacoinvasive therapy compared to transfer for primary PCI and evaluated, number one, the safety and efficacy of reperfusion defined by the resolution of chest pain as well as ST elevation, but also the safety of this approach with intracranial bleeding or bleeding requiring transfusion, and also other outcomes such as cardiac arrest, renal failure requiring dialysis, as well as intra-hospital mortality. So what did the study show and what are the findings? Very interesting finding presented at the Circulation Interventional Journal. As we know, this is a very sick patient coming with a STEMI and with shock. So what they found that patients who underwent pharmacoinvasive approach had better resolution of symptoms, faster resolution of symptoms in 125 minutes compared to 419 minutes in patient undergoing pharmacoinvasive compared to transfer for primary PCI, as well as resolution of more than 50% of ST elevation, suggesting reperfusion. Interestingly enough, the pharmacoinvasive therapy was also associated with a bleeding, intracranial bleed, and bleeding requiring transfusion that is lower compared to the primary PCI. However, this difference in bleeding was not statistically significant. Furthermore, there was also lower risk of in-hospital mortality in pharmacoinvasive group, as well as kidney failure requiring dialysis, as well as patient requiring or hospital death or cardiac arrest, or the requirement for mechanical circulatory support favoring pharmacoinvasive therapy. Again, this is a very important study, although in certain big city centers, we rarely use this approach, but definitely in rural areas, what patient, when presented to non-PCI capable hospitals, it's recommended and favors pharmacoinvasive and then transfer to PCI capable center after an implementation of pharmacoinvasive therapy with no significant bleeding risk and less in-hospital mortality, the need for mechanical circulatory support, and cardiac arrest. Very interesting study. Again, it can be implemented in different centers in Europe, United States, and North America as well. But again, this is something should be validated in a randomized trial to implement to see if the pharmacoinvasive still continue to be favorable compared to primary PCI when patient presented to non-PCI capable hospitals. Thank you again for watching us on Cardiology Update. Follow us on Instagram, LinkedIn, and Facebook, and also on the podcast. This is Chadi Alraies from Detroit Medical Center, and this is Cardiology Update.